It's about understanding what the NHS is currently using, so what is the intervention that's being used? What are the comparators out there? What are the alternatives and how do they compare to what you are proposing to bring in? And finally, it's always about the patient outcomes. If you cannot demonstrate a patient outcome, it will be very difficult to get into the NHS.
Addressing unmet need is a big factor in health technology and making sure that technology is adopted in the NHS. We're joined today by Vee Mapunde, who's the Programme Director for the NIHR's Surgical MedTech Co-operative. Vee, if you'd just like to introduce yourself, please.
Yeah, sure. Hi, Matthew. And as you've correctly introduced me, yes, I'm the Programme Director for the NIHR Surgical MedTech Co-operative. We also have a clinical director, so I look more after the operational elements, and naturally the clinical director is an academic surgeon, and their input is very valuable, particularly for the clinical insights. And for those that aren't too familiar with the NIHR, I think it's just useful to have a bit of context to it. Basically, it stands for National Institute for Health and Care Research, and we are funded by the Department of Health and Social Care in England to support the development and evaluation of medical technologies. Our focus is surgery. However, there are 10 others that look at different clinical areas.
Of course. So you say your focus is surgery. Of course, that falls within your remit as the Surgical MedTech Co-operative. Tell us a little bit about that and about your role in fostering health tech innovations within the NHS.
Yeah, sure. So the Surgical MedTech Co-operative, shortened to Surgical MIC, MIC. So what we are funded to do by Department of Health really is to bridge the first valley of death. So if you're an innovator, you'll be familiar with that. But it's usually the point where as innovators, they come up with concepts, they come up with ideas. They might have a very loose prototype, but then they now need to secure funding to actually do the proof of concept. And usually the funding that they request, it's not large amounts, but those small amounts are actually very difficult to find. If you're looking for funding, people are usually wanting you to request in upwards of possibly £100,000. And most of the times we found innovators in our space are really looking for, anything between £5,000 and £50,000. So what our remit really is about, it's, provide facilitating activities within that space. So this could be clinical validation. So helping to direct them in terms of, are you, focused on the right area? Are you going in the right direction? This could be around proof of concept. Sometimes in a lab setting, we do have academic collaborations, and it's also about proof of concept as well in a clinical setting, because this can actually make or break that particular innovation at that early stage. And this moves through all along in terms of pilot feasibility studies. People will be familiar with that, all the way to the large scale, randomized controlled type studies. I mean, obviously, for MedTech, it's very difficult to do a randomized double-blind controlled trial. But what we do bring to the table is methodology that, sort of offers a similar type of gold standard for your particular innovation. So it's not a one-size-fits-all, but we do work with methodologists, both in the clinical trial space as well as the health economics as well, which is particularly key if you're looking to get your technology adopted in the NHS. One of the things I'll add just briefly is in their current format, the cooperatives are actually coming to an end on the 31st of March, 2024, and they will be replaced by things called Health Tech Research Centers. So that will be another acronym for people to know, or HRCs. And we will do similar things. I think the only difference is we're going to move into sort of the regulatory sort of advice space, market access space, as well as training and capacity building.
Of course, in showing that your technology works, the first thing you have to do is show what it addresses. And there are many areas, of course, in the NHS of unmet need where technology could make a difference. In your experience, what are the biggest opportunities there? What are the biggest areas of unmet need where technology can respond?
In terms of biggest areas, I think it's best to look at it in terms of the pathway for healthcare within the NHS. So you've got your you've got your primary care, for instance. And I think the first priority there really is about diagnostic capabilities. So how do we get better diagnostics into the hands of GPs, for instance, or centers that patients would normally get to, because typically that's where the block tends to be. So how do we get better diagnostics so that we are very sure that what we are seeing is what we think it is? So in the context of surgery, for instance, it's diagnostics, around kidney injury, for instance. It tends to be a high risk factor for surgeries. Your kidneys really need to be in the best shape possible. If you're looking at things like cancer, for instance, which often need surgery as a treatment modality, are we sure we're looking at colorectal cancer? Are we sure we're looking at potential pancreatic cancer? So diagnostics, absolutely big thing, huge unmet need just across the board within the NHS. The second area, particularly in relation to surgery, is about minimally invasive technology. So for surgery, and most people probably won't be really familiar with, is actually your body doesn't like being cut up and open. So it often resists that. Or, you sort of stand to get post-operative complications that can come through. So the biggest challenge is usually around minimizing those risks to surgery. And currently within surgery, there is a surgery fitness test, which works well if you're healthy, fit, you exercise, you don't have mobility issues. But if you're like millions of other people with other conditions, other chronic conditions, you cannot undertake that test. So surgeons then have to, use sort of risk models or try and predict, well, actually, is the risk greater for you going through surgery, or should we sort of leave you alone to it and see what happens? So anything that can minimize, cutting you open and sort of playing around inside would definitely help, or that can do something on the outside. And the final element to interesting, technologies to address unmet needs will be around post-operative care. So once you have surgery or once you have treatment in an acute center, how can we make sure that you are recovering while at home? So this tends to be things around remote sensing technologies, or wearables, for instance, is becoming a huge thing. Is how can we make sure you're recovering while at home? How do we make sure that you are not sent back in the back of an ambulance to a hospital following a major procedure in a hospital setting?
So I think you described there the whole range of areas where technology can make a difference, from effectively in a very peri-surgical environment, you might say, from the beginning of diagnosing what might be wrong through to the discharge process, and after that, when patients have actually had their surgery or had their treatment, and ensuring that the outcomes are as optimal as they might be. With that range of things where technology might respond to, how can innovators best demonstrate to the market that they can actually respond to the real need that exists?
I think that's good, because that's usually the challenge for innovators, and I think one of the biggest criticisms of the NHS has always been, well, we don't know what you want. And it's quite difficult. I mean, the NHS is large, and how do you do that effectively? But I would say it's about understanding the clinical pathways. Most of the times people have got an idea of what a clinical pathway looks like, but they can actually be very complex. So it's about, first of all, understanding those clinical pathways, and the people that are best placed to talk to you about those are the clinicians, are the healthcare professionals. They understand what happens from the point you ring for an appointment to your GP to the point you end up in a hospital. They set pathways that have been, there's processes in place for that. So it's, first of all, it's understanding those pathways, because then you can start to visualize where your particular technology fits in that pathway, or where it could actually potentially disrupt it. And disruptive can be used in both the negative and positive sense. It can negatively disrupt that process by adding more costs further down the line, or actually reducing capacity, or it can be used in a positive sense in terms of disruptive technologies, where they're game-changing, they're life-changing. They can literally change the course of how certain things are done. So, for instance, one example of something that was considered a disruptive technology when it came in was laparoscopic surgery, because before then, most surgeries were open surgeries. You had your abdomen possibly fully open, but now you basically stick ports in certain parts of your body with cameras. They go in and you can actually undertake the surgery that way. So laparoscopic surgery was that disruptive, that, open surgery is actually becoming a rarity now because just about every surgery is being done laparoscopically. It's also about understanding what evidence is required by the NHS. I think quite often, innovators will make assumptions about what evidence there is, and sometimes the evidence is tailored towards what investors want or from a business sense. But evidence from the NHS side is always tied to patient outcomes. I think one of the things innovators need to keep in mind is the NHS is it's funded by public money, it's taxpayers' money. So it's not always about having the shiniest gadget around. If we introduce your innovation, what is the direct impact on patient care? Is it going to reduce the number of people coming in? Is it going to increase the number of early diagnoses for certain conditions? So that's what innovators also need to understand. And once again, there's different people along the pathway. You've got clinicians who've got their own evidence. It's also about understanding who pays for that innovation. Just because it's used in a hospital doesn't mean it's the hospital that's paying to bring that in. There are other players in that healthcare sector that possibly hold that budget. So you need to talk to those people instead of always rushing to the procurement department, for instance, for every NHS trust. And the final bit around that, in terms of just summarizing how they can understand, the best way to demonstrate is to always remember it's about, you've got to understand who the patient is. So the patient population needs to be absolutely clear. It can't be a vague population. It can't be a generic population. It's about understanding what the NHS is currently using, so what is the intervention that's being used? What are the comparators out there? What are the alternatives and how do they compare to what you are proposing to bring in? And finally, it's always about the patient outcomes. If you cannot demonstrate a patient outcome, it will be very difficult to get into the NHS.
Given what you've said around the need to address outcomes and the need to address clinical needs and to be disruptive but in a positive way, do you think enough companies understand the needs they're solving fully? Do you think that health tech innovators sufficiently, for example, engage in co-design? You mentioned talking to clinicians. Do they do that enough? Do they really understand the needs of the users that they're trying to serve?
I would say in some cases, I won't put percentages on these, but I'll probably definitely say there's a lot of cases where, no, they don't fully understand, what problem they're solving. I think, what tends to happen is innovators gain access to a particular technology or a new way of doing something, and then they often try to apply that to a certain sector or a healthcare area, which is actually not the right way to do it. So it's almost, we've got a solution, let's find a problem, whereas you actually need to understand what that problem is first to see what that solution fits. And that is why they end up facing a lot of challenges in terms of getting it adopted into the NHS, because you are not solving a problem for the NHS. All you've done is solved a technology problem. You've shown us that you've been clever enough to use AI in this particular context, but it's actually not solving a problem for the clinician. And I'll sort of give you an example of a technology we had where it was designed for primary care to basically input into the system, and then the system would be able to tell them whether this patient was ready for surgery, whether they needed to lose weight first, whether they needed to do X, Y, Z. But when we spoke to the surgeons, in this instance, they said, well, it's not telling me anything new. With 20 years, 30 years experience, I can tell just by talking to somebody and looking at their notes whether they're ready. It's not necessarily going to speed up something. It might be useful as a training tool, but not as an operational tool. What would have been useful to the actual surgeon was, well, actually, if I put in all this data, are you going to tell me the treatment that is right for this particular patient and the risk that is likely to be successful and the risks associated with their post-operative care? If it can't do that, then it's not solving a particular problem. You also have other issues around where you're dealing with sort of hardware-related technologies. You run into the things around ergonomics, for example. Is it something that's going to induce repetitive strain, for instance? So, with robotic surgery, surgeons often hunched for, long periods of time. There's a lot of concentration required. So that hints at, needing usability studies, and sort of usability testing along those lines. There's things around the patients as well. If it's a technology that needs to interface with patients, how sure are you that you're going to use it? So there's a lot of technologies at the moment where, well, actually they can go on any smartphone and the patient will use that, or the patient can download this app and they can do that. And I know from my own experience and from plenty other people, because it's well documented, there's loads of apps that come out. They seem fun to start off with, and you might use them religiously for the first 4 weeks or something. And then afterwards you just decide, actually, I can't be bothered. And then that's it. So that's one of the things you need to consider is if you want the NHS to roll out this app, why should they pay millions of pounds for an app that people are going to stop using after 4 to 8 weeks, for instance? So it's that kind of knowledge that people need to understand, that it's not simply you've got a snazzy piece of kit. It's what are the other things around that? If you're asking surgeons to do something differently, what is the learning curve? How long is it going to take them to learn how to use that particular bit of technology without causing harm to patients? Because that is going to be their concern. So that is where the co-design helps, because when you talk to the people that are going to use the technology, then they can actually start to flag up some of these things to you quite early on before you spend a lot of money and time on it.
It's been said that technology adoption at scale in the NHS can take as long as 17 years, which is a very long time. And of course, in that time, the need changes, the technological landscape changes. What can technology companies do to get their products adopted sooner?
I think the best piece of advice we tend to keep technology companies is you need to understand who is paying for that technology, because the block really tends to come in the form of you've got a wonderful technology, but either it doesn't fit into some reimbursement pathway, or, the people who are paying for it aren't happy with the evidence for that. So the first thing is always understand who is paying for that particular, innovation. Is it something that the NHS trust procurement normally pays for? Is it something that's normally done by the commissioners or integrated care boards or integrated care services? Who exactly is paying for this technology? That is very important to understand, because then it will influence, first of all, the development pathway and what evidence you need to get. So not every single device or technology needs to go through NICE, for example. So NICE have got specific devices that they see and that they provide guidance and recommendations for. And that's to suit a particular type of payer. There's other organizations that look at, for example, with the digital technology and things like digital apps, there's another bit that actually looks after that. So understanding how the money flows helps you understand, first of all, what evidence you need to generate, particularly health economics related evidence. That's very important. It's always tied to the patient report, patient outcomes. Is the health economics has got to be related to that. It's, sometimes companies naively come and they're looking at it in terms of, well, this device costs, £5,000 and the NHS is currently using a device that they pay, £20,000 for. It's not that type of health economics. It's a bit more complex than that. It's not just looking at the cost of the unit. It's also looking at the cost of treatment across the entire pathway. So from the time a patient goes to the GP and is discharged and certified fit and healthy, you don't need to come back for this particular condition. Or if they need to live with that condition, how is your technology actually saving money? And how is it also benefiting the patient? The second thing is always about it's got to be addressing an unmet need. It's got to be addressing a proper clinical need. It goes back to the point, it can't be generic. It just can't be something that looks snazzy. What is the actual need? What is the actual population you're looking at? What are the requirements for that? And then the final aspect, which is more relevant for possibly digital technologies and, some areas like wound care, for instance. There's just way too many products on the market for that, so you've got a bigger mountain to climb in terms of evidence generation. If you're coming with yet another wound dressing, how is it different to what the NHS has? Try put yourself in the shoes of the NHS. If you had 100 companies all coming to you within the year saying they've got the best wound dressing ever, how are you supposed to make that choice? If all your evidence is turning out to be the same, how are you supposed to make your choice? Is it actually even worth it trying to explore that market? Or are you just better off going into the private sector where maybe people might just buy it because it looks novel? But at the end of the day, it's also about understanding how the NHS makes those decisions.
So I'm just thinking about this more holistically. One of the things you've hinted at is that there's lots of different organisations that perhaps help at different stages. How important really to you is the role of effective marketing in helping companies to gain traction with innovations that could really help?
I think in terms of marketing, I think it's being targeted. I think once again, you get a lot of generic marketing. It's almost a similar instance to pitch decks, for instance, where we get pitch decks that work really well if you're an investor, but they don't work at all if you're talking to a clinician. So I think when it comes to marketing, it's understanding. And I mean, obviously, I'm no marketing expert, but I think back in the days at uni, there was something about the 4 Ps of marketing. And I think that still pretty much applies in the medtech healthcare sector is, you've got to understand your market. Your market is not interested in your global projections. It goes back to, what is the claim you're making and what are you basing those claims on? So obviously working with organizations that understand healthcare marketing works to an advantage because it puts your technology out there. It makes it visible. And I think possibly one of the challenges that innovators have is it's very difficult to gain that visibility for the NHS side of things is how do the decision makers get to find out about your particular product, even once you've finished everything and you now need to get it out there? How do you increase that visibility? So effective marketing really is about understanding the market. What information do they want to see? It's not really about the lovely algorithm that's gone into the back of this AI thing is, tell us how it's actually going to help our patients and what you're basing that on. Where can we find out more information? And that tends to hook in, the decision makers in terms of, well, let's take a closer look at this. There's also obviously things like events, naturally. So it's also about finding out the events where these decision makers go to. Another place tends to be things like conferences. So for instance, with surgeons, as with any other healthcare professionals, they've got their own associations, they've got their own conferences. So it's about actually gaining a spot at that and being able to talk that through. But I'd probably only advise that if you've actually worked with healthcare professionals in their development, because they could equally rip you apart as well if they don't feel initial questions have been answered.
Absolutely. I think working in that environment, we would always say to our clients, think about your audiences, think about the channels that they consume content on, and produce appropriate content that's going to resonate with them on those channels. And that's what we do with health tech companies every day to help them get noticed. Given that very busy environment, how do you think that health tech companies can cut through the noise?
I think cutting through the noise means being absolutely honest and truthful about your particular innovation. I think if you've got an incremental technology or innovation, you will struggle to cut through the noise. You're doing, it's a sort of a change from, okay, you've got an electronic healthcare system, but you've added some fancy bit on top of that. That's considered incremental. It's not exactly radical. So, if you want to cut through the noise, you've got to have something that is really, really groundbreaking, that is going to literally change the way the entire industry does a particular procedure, or how they offer a particular service. That is really the best way to cut through the noise, is about being honest about how radical your particular innovation is. And the clinicians will be able to tell you whether something is radical or not. And I'll give an example. So, we had a company come to us and they had some patch that could measure some particular enzyme, for instance. but they wanted to use it for wound care. And wound care, I always mention wound care because that's one example of a market that's very noisy, loads of competitors. It's just too much going on in there. And it's actually very difficult to secure engagement because people are there's just fatigue. There's just too much supposed innovation in technology in that area. And what the surgeons came back and said was, well, actually, if your patch could detect an enzyme that is released when muscles start to break down, we could actually use that for amputees, or we could use that for people with chronic leg wounds, at risk of developing them. Because if we can detect when something's about to happen, we can actually do something about it. We don't want something that's going to tell us something that's already happened. But if we've got a patch that we can put on somebody and it can actually detect muscle deterioration or muscle death before it is actively visible to clinicians, that is something that is going to be groundbreaking. That is something that is going to be innovative because that means you can use it in multiple settings. So those are the things that clinicians look like. And if you want to look at, and if you want to cut through the noise, then you've got to be offering something that is very radical. So that's really the main thing. And I think a second aspect of it is just, once again, it's understanding the landscape. It's understanding the people that make the decisions. What do they consider as being radical? So I know at the moment, we're getting a lot of people that have got, for instance, innovations for scheduling operations, or scheduling waiting lists. As clever as those software technologies might be, they're not considered radical by the people who pay for them. So you find it very difficult to cut through the noise as a result of that.
Interesting you should draw on that example. We do have a client that's doing that, and they are managing to get quite a lot of attention, but they are approaching it in a very different way, and completely changing how waiting lists are managed. So perhaps that feeds back into what you're saying.
Yeah.
Moving forward, what really excites you about the potential of technology in supporting the NHS? What does the future hold?
I think for me, it's to do with risk prediction. The potential to use artificial intelligence, for risk prediction in early diagnosis. I think we're only starting to understand how much data has been going on all around us, uncollected, and AI gives us, offers that particular potential to be able to do that. So in terms of early diagnosis, there's obviously things around how can we use AI, particularly for imaging. Actually, can we, diagnose certain things before they happen? Are we able to detect certain things through normal modes before they happen? Another aspect of it as well is things around risk prediction. So can we actually predict if somebody's at risk of having a major event once they have an operation and we release them at home, So within colorectal surgery, there's something called post-operative ileus. And that's where when they do abdominal surgery, sometimes your intestines sort of go to sleep and they forget to wake up and do the work that they should do. And obviously that's a major risk because that means everything sort of gets stuck in there, nothing moves. And, if it gets really bad, then your intestines can rupture. And it's how can we detect that someone who's at risk of having that particular side effect happen to them sooner rather than them actually coming in the back of an ambulance. Similarly, working with our colleagues in the diagnostics factor, you've got acute kidney injury, where, it's very difficult to diagnose that. And sometimes patients can seem very healthy, they go home, but then they come back 2-3 days later in a worse condition than they ended up in hospital with originally in the first place. So for me, that's got to be the most exciting aspect about that, because that automatically means we can tailor better treatments, have more personalized treatments. And it just means people have less invasive therapies if we are able to catch things early on.
Vee, thank you for your time today. That's been incredibly insightful. Much appreciated.